Imagine you are maybe 2 hours into a facelift. You're dissecting inferior to the zygomatic arch, making what feels like totally routine progress.
Right. Everything's going smoothly.
Exactly. And then suddenly, the patient's forehead stops wrinkling on the right side. You have just hit the frontal branch of the facial nerve.
Oh man, that is the absolute nightmare scenario.
It really is a nightmare. So, to make sure that never happens to you, welcome to this high-yield revision deep dive. If you're a resident preparing for your plastic surgery board exams, like the FRCS, this session is engineered entirely for you.
Yeah, we are skipping the fluff today. We're stripping away the surface facade and getting right into the structural framework of the face.
Because passing your boards and, well, more importantly, keeping your patients safe in the operating theater, it requires knowing the unforgiving anatomical reality, not just the steps.
Exactly. The anatomy dictates every single one of those surgical steps.
Right. And a quick note directly to you, the resident listening right now. This session is tailored specifically to test your knowledge and explain the why behind what you do in the OR.
And we are not wasting any time.
We're not. But before we jump in, do take a second to press follow on the show so you don't miss our future deep dives, and leave a rating if you learned something valuable today.
Yeah, that really helps.
Also, if you want to take your exam prep to the absolute highest level, our premium subscription is the only way to access the exclusive Journal Club and Clinical Cases deep dives.
Which, are essential for your oral board prep.
Totally. They're reserved specifically for premium members. Okay, for today's format, I'm going to throw targeted board-style questions out, and we are going to break down the anatomical mechanics behind the answers. Let's start at the absolute foundation.
Let's do it.
To perform a safe facelift, you have to master the architecture. So break down Dr. Brian Mendelssohn's concept of the 5 concentric layers of the face. How do they mirror the scalp?
Right. So Mendelssohn's paradigm, it completely shifted how we understand facial aging. Because he proved we aren't just dealing with stretching skin,
We're dealing with structural collapse.
Exactly. A predictable, layered architectural collapse. So the face is built on 5 concentric layers, directly mirroring the scalp. Layer 1 is obviously the skin.
Right.
Layer 2 is the subcutaneous tissue and fat. Then layer 3, this is your continuous musculoponeurotic layer.
The muscle and fascia.
Yeah. Then layer 4 is the loose areolar layer, which is where the facial spaces live. And finally, layer 5 is the deep fascia, or periosteum, the bedrock.
So layer 3 seems to be the one that trips residents up on written exams, mostly because it doesn't just go by a single name.
Oh, constantly. It's a huge trap.
Right, it's this continuous, uninterrupted layer that drapes over the entire head and neck, but the nomenclature shifts entirely depending on the regional real estate.
Exactly. Over the top of the scalp, we call it the galea. Move down over the forehead, it's the frontalis muscle.
And as it sweeps laterally into the temple, it becomes the superficial temporal fascia, right? Which is also called the temporoparietal fascia.
Yeah, same thing.
Mhm.
Around the eyes, it acts as the orbicularis oculi muscle and its fascia. Then in the mid and lower face, it is the SMAS.
The superficial muscular aponeurotic system.
You got it. And finally, as it crosses the mandible and drapes down the neck, it's the platysma. But it is all the exact same architectural layer, layer 3.
Okay, so understanding that continuity is the key to mastering the dissection planes. Like if you were in the correct plane in the cheek, you can follow that exact same layer all the way up into the temple.
Right down into the neck, yeah. But what actually dictates the movement of these layers are the anchoring structures.
Right, let's unpack this with a mechanical analogy. If the retaining ligaments are the structural anchor points holding these layers to the bone, the facial spaces in layer 4 are like the loose fabric between them.
That's a great way to picture it.
So when a patient sits in your consultation room with severe jowls or like pronounced molar mounds, is it because those rigid anchors are failing, or is the loose fabric just stretching out?
It's the anchors. The primary culprit is the laxity and degeneration of the bounding ligaments.
Wait, really? So the spaces aren't stretching?
No, the spaces in layer 4, specifically the prezygomatic, premasseter, and masticator spaces, they are completely devoid of attachments.
They're just empty glide planes.
Exactly. They exist simply to allow the mobility of the overlying tissues so we can, chew, speak, emote. They are walled in by the retaining ligaments, which provide the actual stability.
So the spaces just sit there doing nothing, and when the retaining ligaments that wall them in finally give out, gravity just takes over the fat and tissue above them.
Yeah, take the prezygomatic space in the midface. It's walled in by the orbicularis retaining ligament superiorly and the zygomatic ligaments inferiorly.
Okay.
Over decades, when those bounding ligaments stretch, the entire space bulges outward and sags. Clinically, you see a molar mound.
Oh, wow. And the exact same mechanical failure happens in the lower face, right?
Absolutely. The premasseter space is bounded by the platysma auricular fascia posteriorly and the masseteric ligaments anteriorly. When those degenerate, the fat billows forward.
Forming a jowl right behind the mandibular ligament, which aggressively deepens the labiomandibular fold.
You nailed it.
Well, for the boards, we have to be extremely precise with our terminology regarding these ligaments. Examiners will ruthlessly test the difference between true and false retaining ligaments.
Oh, they love that question.
Right. So true retaining ligaments are the primary load-bearing pillars. They travel all the way from the superficial dermis deep down to the periosteum, a direct, unyielding bony attachment.
And the classic examples there are these zygomatic retaining ligaments, which residents often recognize as McGregor's patch.
Right, McGregor's patch. Plus the orbicularis retaining ligament and the mandibular ligament.
Exactly. Now, false retaining ligaments, on the other hand, they only travel from the dermis down to underlying fascial layers. They never reach the bone.
Like the platysma auricular fascia and the masseteric ligaments.
Spot on. But knowing the layers and anchors is really only half the battle here.
Because of what hides between them.
Exactly. Knowing what hides between them is what prevents a routine cosmetic case from turning into a catastrophic complication.
Let's pivot directly to those danger zones. The facial nerve, cranial nerve 7th, enters the face safely buried within the parotid gland.
Right, and it exits anteriorly, lying on the surface of the masseter muscle, safely protected deep beneath the masseter fascia in layer 5.
But it doesn't stay in layer 5. It has to travel superficially to innervate the mimetic muscles in layer 3.
And that transition, going from layer 5 up to layer 3, is the highest risk moment of a facelift.
Because the nerve branches change planes precisely at the vertical line of the retaining ligaments, right?
Yes, specifically the zygomatic, masseteric, and mandibular ligaments. The branches most at risk are the frontal and mandibular.
Let's break down the frontal branch, because the 3D anatomy here is incredibly specific. It's sandwiched right over the middle third of the zygomatic arch. So how exactly do we avoid it?
You have to visualize the anatomical sandwich perfectly. The frontal branch leaves the parotid just inferior to the zygomatic arch.
Yep.
Then it passes superficial to the middle third of the arch. At this precise point, it is sandwiched between the superficial temporal fascia above it, which is layer 3, and the deep temporal fascia below it, layer 5.
Wrapped in a continuation of the parotid masseteric fascia, putting it squarely in layer 4.
Exactly. So to protect it, your surgical strategy has to be absolute. You drop down and dissect deep to the nerve, gliding directly on the pristine, gleaming white surface of the deep temporal fascia.
Drop deep to protect the nerve. Got it. Moving down the face, the mandibular branch presents a totally different trap. It's at highest risk where it's fixed against the ligaments.
Yeah, tethered by the platysma auricular fascia posteriorly and the mandibular ligament anteriorly.
So to protect it, you must keep your dissection superficial to the platysma. But here is the oral board trap, right? Textbooks say it runs 1 to 2 centimeters inferior to the mandible border.
Right, but as the lower face becomes toptotic with age, that distance actually increases. The nerve drops much lower than the textbook suggests.
You also have to track the sensory nerves and the blood supply. Down in the neck, the great auricular nerve is the primary hazard.
Yeah, arising from the C2 and C3 roots. If you carelessly divide that, the patient wakes up with permanent numbness of the lower pinna.
And the landmark for that is super reliable. It emerges from the posterior border of the sternocleidomastoid, exactly 6.5 centimeters inferior to the tragus.
6.5 centimeters, burn that into your brain.
And regarding blood supply, there's a specific vessel in the temple that requires immense respect, the middle temporal artery.
Because injuring it doesn't just cause a bleed, it causes a long-term aesthetic deformity.
Right, it supplies the deep temporal fascia and its fat pad. If you injure it, you get fat pad atrophy, leaving the patient with really noticeable temporal hollowing.
Since a millimeter dictates whether a nerve is cut or an artery is sacrificed, our preoperative assessment has to be just as precise.
So transitioning from the textbook into the consultation room, how do we logically assess the face by thirds?
Starting with the upper third, it's heavily focused on the hairline and brow position, and there's a non-negotiable gender difference here.
Right. In males, the ideal brow sits flat right at the superior orbital rim. But in females, it should arch above the rim with the apex aligning vertically with the lateral limbus.
Exactly. And you're actively scanning for bractosis. If they have deep transverse forehead creases, that's not just a skin wrinkle.
It's compensatory frontalis contraction. They're lifting their eyebrows just to see.
Yeah. Now, moving to the middle third, residents often fall into a trap differentiating true malar mounds from palpebral bags.
Totally different anatomical problems. Malar mounds are bulges of skin and fat over the malar prominence due to laxity in the prezygomatic space.
But palpebral bags are higher up, under the eye, caused by postseptal orbital fat bulging through a weakened orbital septum.
And you also assess for festoons there, those cascading folds of redundant orbicularis oculi muscle.
Right. Down in the lower third and neck, you're looking at mandibular projection, marionette lines, and jowls.
And palpating for platysmal bands while calculating the cervicamental angle, which should be tightly between 105 and 120 degrees.
Anything more obtuse means submental fat or platysmal laxity. But the consultation isn't just about what we can fix.
Here's where it gets really interesting. Setting firm boundaries. What must we explicitly tell patients a facelift will not fix?
You have to be blunt. It does not address forehead lines or crow's feet. It won't fix palpebral bags under the eyes. That needs a blepharoplasty.
It doesn't erase deep nasolabial folds either.
And it absolutely will not correct fine perioral wrinkles around the mouth. Those smoker's lines need skin resurfacing, like a peel or laser. The lymph won't cure them.
We must also be brutally honest about complications, particularly hematoma. It's the most common immediate complication, overwhelmingly within the first 24 hours.
Requiring prompt surgical evacuation so you don't get flap necrosis. And the stats are stark, mostly based on gender.
Right. In females, the hematoma rate is roughly 1 to 3%. But in males, due to the vascularity of the beard area, it jumps to a massive 7 to 9%.
That's a huge jump. And skin necrosis is another devastating one, happening in 1 to 3% of cases, usually post-auricular where the flap is thinnest.
The critical counseling point here revolves entirely around smoking. Smoking restricts microvascular blood flow and increases the risk of skin necrosis by a staggering 12-fold.
A 12-fold increase in tissue death. Patients must stop smoking well in advance.
It's a boundary you simply do not cross. Okay, so we've diagnosed the failure, warned the patient, mapped the danger zones. Let's move to the surgical arsenal.
Right, let's categorize facelift techniques based on the plane of dissection and SMAS manipulation.
We can dismiss subcutaneous skin-only lifts entirely, right? High recurrence risk, because pulling layer 1 skin does nothing for the structural collapse of layer 4.
Exactly. To get a lasting result, you manipulate the SMAS. In a traditional SMAS dissection, you make an inverted L incision.
The transverse limb runs inferior to the zygomatic arch. Vertical limb drops down the sternocleidomastoid.
Right, you free the mobile SMAS, redrape it posterosuperiorly, trim the excess, and suture it back.
But a traditional SMAS mostly addresses the lower face. The extended SMAS was developed for the midface.
Yeah, you take the transverse incision higher, above the arch, and extend medially over the zygomaticus major.
Pulling those midfacial tissues up for malar augmentation. What about semisectomy versus SMAS deplication?
In a semisectomy, you literally excise a strip of the SMAS along an oblique line from the mandibular angle to the lateral canthus. Suture the edges, and it tightens the lower face.
I always found that counterintuitive. If an aging face is losing volume, why cut away viable tissue? Why not just use SMAS over it, folding the SMAS over and stacking it to build volume?
And that folded dog ear at the top actually augments the deflated malar region. But it's a biomechanical trade-off. For heavy faces, SMAsectomy removes bulk. For thin faces, poplication restores volume.
Make sense? Let's talk MACS lift, the minimal access cranial suspension.
Short scar variant, purely vertical lift, no postauricular extension. You weave purse string sutures into the SMAS and suspend it rigidly to the deep temporal fascia.
Powerful, but since it's vertical, it can cause severe bunching of skin below the earlobe.
And risks elevating the temporal hairline if you don't use a stepped incision.
Let's go deeper. The subSMAS, or deep plane facelift, classically Skoog's procedure.
Your cheek dissection is entirely deep to the SMAS here. You move layers 1, 2, and 3 together as a composite flap.
Which gives it a highly robust blood supply, so it's vastly less prone to necrosis. Huge advantage for compromised skin.
But the disadvantage, you are millimeters from the facial nerve branches, so the risk of motor nerve damage is way higher.
Finally, the deepest plane, the superior steel approach by Tessier, often endoscopic now.
The massive advantage is absolute protection of the facial nerve because you're scraping on the bone. The nerve is entirely superficial to you.
But it has very limited effects on severe laxity in the lower face and neck. Speaking of the neck, when we see medial platysmal bands, what's the surgical sequence?
Step 1 is submental defatting, open or closed.
Okay, step 2.
Address the divarication. You plicate the medial borders of the platysma tightly together through a submental incision.
Like creating a muscular corset.
Exactly. Step 3 secures the lateral pole. You suture the lateral edge of the platysma tightly to the platysma auricular fascia or mastoid periosteum.
And finally, step 4, suspending pulpotic submandibular glands to restore that 105 to 120 degree angle.
That is the complete architectural roadmap. So to synthesize, Mendelssohn's layers dictate your plane. True versus false ligaments define the spaces.
And navigating the SMAS requires deep respect for the frontal and mandibular nerve branches. This leaves us with an important exam-level concept to chew on as you study.
Yeah, think about where the field is going.
Consider how our approach to facial aging might evolve. If aging is truly a failure of both the restraining ligaments and the volumetric spaces they border, will future techniques completely abandon superficial skin tension?
It's fascinating. Will we focus entirely on internally restoring the deep structural framework of layer 4 and just let the skin passively redrape?
Understanding that tension between deep framework and superficial aesthetics is what separates a technician from a master surgeon.
Because the face isn't just a surface, right? It's a dynamic suspension bridge.
Perfectly said. To everyone listening, if you want to crush your FRCS or board exams, you have to engage actively with this material. Do not just passively listen.
Drop down below the track right now.
Yes, leave a comment or a question about today's deep dive. Challenge a concept or ask for clarification on a nerve pathway. We read every single one. Keep studying the blueprint, respect the anatomy, and we will see you on the next deep dive.